Okay, now I'm recording this session, so I hope you have not any inconvenience on that. We are 1 hour ahead webinar, in which we are going to have Martin Thyssen from Robert Koch Institute in Germany, who is going to talk about the research use cases in PHIRI. Then I'm going to talk a little bit on the process, on what we are doing in the use case, one of the use cases in this, on the impact of COVID-19 on mental health. We are also having Sarah Aldrich, who is going to talk about the experience on this use case in Wales. Also, Alexander Grabenhofer-Egger from Austria is going to talk about the one related project, which is called the Implemental Project. And finally, I hope we have enough time to debate or to ask questions to the speakers. So I hope you enjoy this session, and I'm going to stop sharing my screen, and I invite to Martin to share his screen and to speak about what is PHIRI and what the use case are meant to be. Okay, thank you, Martin.
Can you hear me? All right, very nice. Thank you so much, Carmen. And you can see my presentation in the presentation mode, right? Brilliant. Awesome. I had some technical issues today. I don't know what's going on, but I hope we soon can meet in person again. That makes everything a little bit nicer and more personal. Anyway, thank you, Carmen, for the introduction. I'm very happy to be here today and presenting the background a little bit of today's workshop, talking about the PHIRI project, Population Health Information Research Infrastructure, and the research use cases that we are conducting within the project. And this is the basis for the other presentation that will follow after mine. So I'm very happy. My name is Martin Thyssen. I'm working at the Robert Koch Institute, the National Public Health Institute in Germany, and in the Department for Health Monitoring and Epidemiology. And we are leading the work package on the research use cases. First of all, what is PHIRI? For those who don't know the project, PHIRI, as I said, is Population Health Information Research Infrastructure. And this research infrastructure facilitates facilities that provide resources and services for research communities to conduct research, and through that foster innovation and support policy decisions. That's the main purpose of the project. We have 3 years for the project, from November 2020 to November 2023. So we have the half of the project is over right now, and we cover 41 partners in 30 countries. These are national public health institutes, these are universities, and also ministries of health. As you can see, we cover a broad partnership with many countries in Europe, which is very nice. Within the PHIRI project, there's one work package dealing with PHIRI with research use cases. These are 4 real-life use cases measuring the impact of COVID-19 on population health. You can see them on the left side. The first one is on vulnerable population groups. The second one on delayed care in breast cancer patients. Yeah. The third one, okay. The third one on perinatal health, and the most important one for today is COVID-19 related changes in population mental health. And this is exactly what Carmen will talk in detail about that. I'm going through the overarching things of PHIRI. What are our aims? Our aims are to demonstrate how a broad variety of secondary data can be pooled and reused across Europe. with the sub-goals, of course. The first goal is to conduct research and to produce results and show them and disseminate them. On the other hand, it's important for the future perspective. These are pilot activities or proof of concept, more or less, for the added value and the benefits of our federated approach. I'm going to talk about that a little bit later, to bring together data from different European countries over borders, GDPR compliant, and feed them into the federated research infrastructure. This is also important in case of sustainability, because that could be a cornerstone of the European health data space. The federated research infrastructure. What are we doing to implement and develop the federated research infrastructure? We have a two-step approach. The first one is what we are doing. We're showing the potential of the infrastructure for rapid cycle analysis by conducting the 4 use cases that I showed to you. And for the future perspective, we want to develop an advanced version implementing distributed analytical solutions. How does it work, the federated research infrastructure? We have a central node, you can see with the question mark in the middle. That's a coordination hub. And these computers are the countries, the institutions, the data providers, which we call data hubs. So it is this architecture is private and safe by design, because there is no data motion, just scripts and aggregated results are shared. So the data hubs host and curate the data they have access to, and they conduct the analysis in their premises. So no data movement. And the coordination hub, the one in the middle, develops codes, scripts for the analytical pipeline based on the research questions and the common data models developed within the data hubs. And if you want to see some results, what we have done in PHIRI and the 4 use cases, feel free to go to Xanadu. The analytical markdown R scripts, as well as the common data models research questions, are all published there. What did we do with the use cases? What is our approach? It's going to be a little bit technical. I try to be as clear as possible. It is kind of a little bit complicated, but in the end, it's a simple process, a harmonized process throughout all the 4 use cases that we build on. First of all, we decided on a research questions and defined the key components, unit of analysis, period of study, and so on and so forth. And afterwards, we set up capability and data access survey, in which we wanted to know about the technical capabilities within the data hubs, because you need some domain experts, of course, to deal with the content, but you also need some IT experts within the data providing institutions. So we wanted to ask, are you capable of using R or Python or whatever? And do you have easy access to data? And based on that, we finalized then the research questions and developed a common data model, and built on that a synthetic data set based on the data requirements of the data models. Okay. And with this synthetic data set, we conducted a data availability survey, more or less a second round survey for the data hubs, in which we wanted to find out if there are gaps between what the data providers are able to contribute and what the original data model requires. Yeah, so we have an overview of how many countries can contribute to our research questions. The next steps were the quality analysis and the analysis and the basic analysis. We conducted both with a synthetic data, and set a validation test for key variables, for example, and see if everything worked smoothly. And in the end, there was another way back. We asked again the data hubs to check our scripts and see if everything is running. This was conducted by the IT experts, while the common data model was more set up by the domain experts. So it's always a back and forth, as I said, between a help desk called here as a coordination hub and the data contributing countries. And in the end, that's now the job of the data hubs. That is the phase we are in right now. They need to access and mobilize the data based on the data requirements in the common data model, and also deploy the PHIRI federated analysis application, which is the Docker. For those of you who don't know the Docker is, as I said, an application. It's our PHIRI approach. It's a virtual environment that is deployed within your premises without being connected to the internet. No data is saved, it's just on the fly, and you can use it to conduct your analysis within the Docker. So this is our approach. And then in the end, share the aggregated result outputs based on the Docker, and then send it back to the help desk, to the coordination hub, where the meta-analysis is taking place. This is our orchestration pipeline. This is my last slide. What have we done so far? What have we achieved? In over 20 data hubs, data is mobilized and ready
No,
to
però
be
è sulla
analyzed.
versione nuova. Perché...
Oh, that's Italian, I guess, right? Anyways, so exactly 20 data hubs. I think it's 24 data hubs, and mobilize the data, which is nice because we really maximize the amount of the number of data contributing countries to show the added value of our approach. In 13 data hubs, the Docker was deployed, which is also related to capacity building. We want the institutions that are contributing to learn to understand what we are doing for any further future activities, right? It's also a capacity building exercise. And the final results are expected within June and will be published on the Health Information Portal, which is very nice. And I invite you all to visit our Health Information Portal. Many interesting information is stored there. So that's it from my side. Thank you very much, and excuse me for any technical problems. Back to you, Carmen.
Excellent, Martin. Thank you very much for the presentation and for introducing PHIRI for those who are not familiar with it. Okay.
My pleasure.
I'm going to start sharing my presentation and to talk about one of the use cases you talk about, which is related to mental health changes due to COVID-19. It's a bit slow, my computer. Okay, it's thinking. Okay, can you see my screen?
Yes.
Okay, thank you. Okay, as I said before, I'm going to talk about this use case in mental health. We all know, unfortunately, what COVID has bring us. A high amount of cases and deaths. These are the global, the worldwide total cases, and these are the European cases. We are not currently 100 million of cases, and we have had 100 million cases in Europe, and 500,000 deaths since the pandemic started. And this pandemic has had lots of consequences in all domains. This is only an example of the people who lost their job in the European Union since the beginning of the pandemic, with a comparison between spring and summer 2020 and spring 2021. Things did not improve in spring 2021. Sorry, 2021. And so people reported being tense, lonely, depressed, and again, things haven't improved after 1 year of pandemic in spring 2021. So as you can see, the impact on mental health, the consequences of the pandemic in mental health are quite extended. These consequences in mental health have been evident since the beginning of the pandemic, and as sooner as 2020, several researchers around the world made calls for action for mental health science, as you can see here. And this is another example of the impact of the pandemic in mental health. In comparison with other respiratory diseases. So in the framework of PHIRI, one of the use cases should be population on the impact of COVID-19 related changes in population mental health. So this was our objective. And as Martin said, we wanted to show how this could be done in a federated way, using the technical capabilities of the different data hubs in Europe. To process, to ask to address this objective, to see the changes that COVID-19 pandemic has bring to mental health. In this work package, we answered 2 questionnaires. One of them was aimed to get a better sense on the access to data and the data hub's capabilities. This was the first survey. These are the countries that contributed with answers, and these are some of the results of the questionnaire, this first round questionnaire. For instance, the questionnaire asks about if the institution hosted health or healthcare data, and if the institution was capable of accessing health or healthcare data from external institutions, if the healthcare data were available at individual level or at an aggregated level, etc. After that, we decided to that the research question this use case wanted to address was, has the mental health status, depression or anxiety, defined as depression or anxiety symptoms of the general population, changed during the COVID-19 pandemic? We wanted to address these research questions using registered data, for using indicators such as prescription of antidepressants, anxiolytics, visit to primary care or specialist care with an episode of depression or anxiety. And also we wanted to use survey data. But finally this was not possible because the survey data did not comply with the specifications. So for each indicator, we define a name for the variable, the groups or categories in which this variable could be grouped, the level, or if the data could be linked to infection, hospitalization, mortality, etc. We also design a common data model according to the research question. In this common data model, as you can see here, we define each variable we wanted to analyze and several characteristics of these variables. For example, for registered data, we wanted to collect the diagnosis using ICD code or SNOMED. For drugs, we wanted to use ATC codes, and for primary visits, we wanted to use ICPC codes. And these were the specifications for the variables from survey data, but finally they weren't used. once we had defined our common data model, we defined a second round survey, which was specific for each use case, to start the process of harmonizing data throughout this common data model. In this second questionnaire, the main question was, can you comply with common data model specifications for each of the variables? And you can see here the results. Most data hubs could comply with most variables, except for socioeconomic level, country of origin, and drug, the treatment. They have not, some data hubs had no information on these variables, and not all data hubs had also all the information regarding visits or perhaps the treatment, as I said before. So we refined, we reviewed the common data model, and some of the variables were considered optional or recommended, but not required, not mandatory. Once we had this common data model and all the data hubs agreed on that, the scripts were designed, the R scripts were designed, and they were published in Synodo, as you can see here, with all the specifications and instructions to run the analysis. Also, the Docker was also published, as Martin has explained before, also in Synodo. This is a screen capture of the Docker with all the instructions, and I can say that it is user friendly. And at this phase, these are the data hubs that can contribute with analysis, with data. Some of them have the first results, the first analysis, the first results available. Some of others are still deploying the data, the Docker, or completing some requirements, legal or ethical requirements. But I think it's a promising results. And here are the data, an example from Finland. They cannot be here today. They had, Mika and Hannah had another commitment for today. So, but they have provided us with the preliminary results from their data. They have used the hospital discharge register from 2018 to 2021 by month, and also the primary healthcare register, also from 2018 to 2021. And these are the results. There has been an increase for anxiety and depression in 2021 and 2021, 2020 and 2021, compared with the year before the pandemic. The number of new patients increased for depression and anxiety in the cases. Also, the visits to mental health care or intoxication care have increased after the pandemic or during the pandemic. But the first visits decreased slightly. So the pandemic had a small effect in the use of specialized mental health services. and also a small effect in the use of primary health services, with an increase in the number of new patients in 2020 in specialized mental health services, and a decrease in the number of new patients for primary mental health services. This pilot exercise has had some limitations. We have found that for registered data, as you have seen before, we lacked some of the data. In some countries, there are an absence of centralized register or fragmented register. We also had a delay in the availability of data, and in some cases also the problem was to identify correctly the patients. And also for all data hubs, there were ethical requirements to access the data, and also legal for some of the data hubs. So in conclusion, the preliminary results suggest that data can be reused in a distributed manner across Europe. The use case methodology is feasible and will allow cross-country comparisons, and some limitations make the process complicated and time-consuming. So that's all from my side, and I would like to give the floor to Sarah from Wales, from the Swansea University, who is going to talk about the experience from Wales. Thank you, Sarah.
Hiya. Thank you, Carmen. Yes, let me just share my screen. Hiya. Yeah, so I'm Sarah. I'm working on behalf of SAIL at Swansea University. So we're, in a collaboration there. SAIL holds is a repository for linked health and administrative data. So we combine health data with census data. So I think there was only one country on your list, Carmen, that could provide socioeconomic score. So I think we're the only one that can do that. But yeah, so it was reasonably straightforward to conform to the data model that you provided. I think the only thing that we couldn't provide was the country origin code. And we can't really do emergency care admissions because we've got a slightly different coding system for that. And the sort of mental health associations in that are very vague. So we couldn't really link it back to depression and anxiety. So we've left that one out. But otherwise we were able to, provide pretty much all of the demographic information, and then all the diagnosis and the treatment that comes with it. So moving on, so our preliminary results, we've started using the Jocker, and generally it's a really lovely interface. It's really nice and clear. It's very straightforward, and it provides all the information that you need. So it's really helpful that you've got all the use case data models on there as well, as well as the artificial data sets as well that have been uploaded. It just really helps to so we know what we've got to look like, and that's been really helpful. We've had a couple of issues with a couple of very small bugs, but the support team is fantastic. So any questions at all, they've got back very quickly, either with a solution, or in some cases we've also been working with the R scripts on their own as well, separately, so that we can try and solve any little issues that were coming along that might be just specific to SAIL. And in those cases as well, we've had lots of feedback. So anything that I've fed back to the team has been really constructive. So that's been really helpful. And then as for the aggregated data as well, we've managed to create a couple of data sets. We've not had them approved out of SAIL yet, but the aggregated data is really helpful. I know at Swansea, so we're involved in a different use case as well, where we want to look at the European age standardized rates. So the aggregated data that's coming out is really helpful because it's linked with things like age as well. So our results are showing similar to what you showed earlier, Carmen. So we've got this drop that occurs around the first lockdown. So in the UK, that's this red line around the end of March. And this blue line here, you can see this huge drop off in diagnosis of depression. And it happens in both males and females, pretty marked in both cases. And then you've got some recovery, but it's not back up to pre-pandemic levels so far. So that's of interest, really, especially if you've got these surveys that are showing that people are still concerned. And then anxiety shows a similar pattern, but not quite as marked. It appears to be back to the pre-pandemic levels, really. And then you've just got this overview as well, which kind of shows it a bit more clearly. Yeah. And then, as for the socioeconomic score, so this is a really useful tool to be able to see whether or not deprivation is a factor within these diagnosis and treatment. And it's really key, I think, to look at whether that effect is disproportionate among these groups. So we've taken the scores, the number of people with the highest deprivation score and the number of people with the lowest, and you just divide them, and it gives you a really nice measure. So we can look at that over a period of time, and it looks like it's changing. There's an existing trend in there anyway, so it's difficult to see whether or not COVID has had an impact on this, but we can look at this across a number of different factors. So this is only for diagnosis, this one, but it'd be interesting to look at the other effects, sorry, the treatment as well, to include that, so just in summary, we've started collecting this data for Wales, and it's really nice to, it's quite straightforward to conform to the data model. The doc is brilliant, and all the scripts that have been provided are really well annotated, and it's easy to go through and make any adaptations that you need. And our preliminary results are showing a drop in anxiety and depression diagnoses since the start of the pandemic, which has in some cases returned to the pre-pandemic levels. I think that's it from me. Yes. Okay. Well, but thanks very much. And then, I'm passing back to Carmen, am I? Thank you. Thanks, Martin.
Thank you, Sarah, and for sharing your thoughts. I see a couple of questions. I don't know if you can wait till the end of the presentations, or perhaps make very quick questions now. Perhaps if you want to unmute yourself and to make questions on.
I can answer a question.
Perhaps for all the speakers we have talked until now.
If I do have a question, but I can wait until the end if you prefer.
Okay. Thank you, Fernando.
Okay.
Okay, now it's turn to Alexander. So I invite you to share your screen, and he's going to talk about a related project that is called Implemental.
Yes, hello from my side. Initially, we also wanted to present preliminary results from Austria, but we are not finished yet. And that gives me the opportunity to speak about another project on mental health, another European project. This is the joint action Implemental, and this is in some way possibly linked, not because my team works in both projects, also in the PHIRI project and in the joint action Implemental, but also what happens if you find out that depression and suicidality increases. We have possibly one answer to this question, what you can do. And today I talk more about possible reaction on some changes due to the pandemic. As I told you before, Austria is involved in both European projects. And the aim of this joint action implemental is the rollout of best practice models in mental health in member states or your other European states. And those two best practice models that should be rolled out is, on the one hand, the Belgian mental health care reform, and on the other hand, the suicide prevention program SUPRA from Austria. And today I will focus on the suicide prevention program and the rollout. 17 states are involved in this joint action. Besides Austria, it's Bulgaria, Croatia, Cyprus, Czechia, Estonia, Finland, Greece, Hungary, Iceland, Lithuania, Malta, Norway, Serbia, Slovenia, Spain, and Sweden. So the time of the joint action is, it started in October 21 and will end in October 2024. And if you want to have more detailed information, you can also have a look on the web page of the joint action implemental. Austria is, together with the colleagues from Czechia, responsible for the working package, for the work package of suicide prevention that is based on our program SUPRA. SUPRA is structuring suicide prevention in 6 columns. I don't want to go too much into detail, just showing you a raw picture of what it's about. And these 6 columns of suicide prevention is coordination and organization, support and treatment, restriction of access to means, raising awareness and knowledge about suicide and crisis, about the embedment of initiatives of suicide prevention in other health promotion and prevention activities, and last but not least, about quality assurance and expertise. During the last 10 years, we based on these 6 columns, we developed a strategy with 18 operative goals and 70 concrete actions. So this is quite large, and you cannot in detail see, but you see it's highly complicated on the one hand. On the other hand, it's quite detailed, and the idea of this joint action is to also put out some details of this strategy that can also be used in other countries as well. And once again, here is the link to the webpage where you can find a bit more if you want to know more details about the Austrian suicide prevention program. The main objective is of the joint action now is to develop, or if it's already in place, further develop or scale up suicide prevention strategies of the participating countries comparable to our model we have in Austria. And it's not a one-by-one rollout of the Austrian program. It's more taking into account the respective national or regional context in the country and select specific elements of SUPRA and bring them to implementation. And it's about implementation. That's why the name of the whole joint action is implemental. Yeah, so the tasks within and the outputs within this joint action is, on the one hand, a situation analysis of the current situation in the countries, and then a needs analysis based on this situation analysis. It's also to obtain stakeholder commitment for the establishment of a national strategy and to have working groups and national advisory boards installed in the countries. And it's pretty much to promote learning and cross-country exchange on methods and tools and practices, experiences of various suicide prevention strategies, and not only strategies, but also on concrete suicide prevention actions. And now I come to the point that is maybe the most interesting one in this context here. One aim is to support capacity and competence building of all the stakeholders. And in the course of the joint action, each year some trainings are planned. And this is highly important maybe here, because the trainings are not only open to the people who actually take part in the joint action, but also to other mental health experts from the participating countries. Yeah, and the idea is to support a sustainable improvement, expansion of suicide prevention in the countries. And the take-home message, I come to an end so that we have enough time for questions afterwards, is if you are interested in the trainings provided during the joint action implemental, and these trainings are mostly on really concrete actions like safeguarding hotspots or establishing of a national telephone hotline, or things like that. If you're interested in trainings on that, please contact the competent authority in your country, and you find these competent authorities and the links to these also on the web page of the joint action implemental. Many thanks from my side.
Thank you, Alexander. Nice presentation as well. Okay, so now it's time for questions and for debate on this use case and related projects. So Fernando raised his hand. So
yeah, thank you. So I have two questions for the first speaker, for Martin. So the first one is, if I understood well, you are developing common data models for each of the different research questions. So have you given up in terms of developing a single common data model for the whole topic of mental health and COVID? Is too difficult or time consuming or just not useful? And sorry, the second one is very easy. Which is the role of the synthetic data sets? Is just for testing the scripts, and how big are they? Thank you.
Thank you very much, Fernando, for your questions. So regarding the data models, we started with the wish to have one data model in the end for all the use cases. Yeah. But during the time, it was easier and more practical for the beginning, because we are testing, right? These pilot activities was easier to have a harmonized approach for all of the use cases, but kind of different data models, which are, all of them are in the same template. So we try to harmonize it as much as possible, but we are planning on that in the future. We are trying to do that because we need these experiences of doing it, as you said, right? Is it easy? Is it doable? Is it feasible? So these are the questions. But this will happen after June, after we have the first results of the use cases, and then in the second phase of the project, we can do these things. We can search for technical solutions. We can maximize our efforts and deal with things like the common data model for all of the use cases. And the role of the synthetic data set, it's basically for testing. It's basically for testing, because the data accessibility in many countries, it took a long time to access these data for the data hubs. Yeah, this is what Carmen mentioned, the limitations. Many institutions are not data holding institutions, so they needed access to the data. And they need to exchange this with some legal agreements or anything. So we needed this synthetic data set to test our approach beforehand, before we use real life data. And that is why we used the synthetic data set. And it was great. It was great to test it. It was very reliable.
Thank you.
Thank you, Fernando.
Okay, are there any questions from the audience? Okay, if not, I would like to start the discussion, perhaps with some thoughts on these. Perhaps they are common to all the use cases. I'm going to start sharing my screen again. Okay, so the first thing perhaps that we can learn from all this exercise is about how to overcome the difficulties, the limitations that Sarah has mentioned, or even Martin or myself. So I would like to give the floor to my colleagues. Perhaps they can share their thoughts about this.
And maybe I could start with some overarching things to overcome these difficulties. Yeah, it's not that easy. As I said, things like these are national difficulties in general. Yeah, these are the national structures, health system structures that we can't overcome from today to tomorrow, right? But what we can do is what I said is building capacity and knowledge, and develop best practices like this and offer it to the research community, right? So this is what we definitely can do to push this process forward and to maybe sustain it in the future initiatives and like the European health data space. So this is maybe the first step to build knowledge, acceptance, to build trust, to build trust. This is very important, that the data holders not just involved within the PHIRI project, but also the other data holders within the countries, that they trust us, that they trust the approach, that everything works smoothly. And it was great to hear what Sarah said about the approach, that it worked very well. So we need to build on that in the future, and then I think we can overcome the first difficulties, the first barriers. Thank you.
Thank you, Martin. Perhaps sharing experiences like this would contribute in the future to overcome, to build trust, and as Martin said, perhaps any thoughts from Sarah or Alexander?
Martin articulated that really well, actually. It's the building these best practices and getting this experience and getting it out there as well, and making it known the issues that we have come up against, so that it makes it easier in the future to continue with these kinds of collaborations, because they're so key. They're absolutely necessary, and it's sort of amazing that it's not already in place. It seems like a very sensible and logical thing to have in place already. So I think it's very, very important to communicate the problems that we have come up against and how we've overcome them. Which I realise doesn't actually answer your question at all, having how to overcome the difficulties. But it's really important that it is.
Okay.
Actually, we of course we have the same problems in Austria, but in parallel to this project, we started to look for new sources of data that we didn't use before. And we have now a project where we get data from telephone helplines and data, police data concerning violence at home. And we tried to get some insight on mental health, or the changes in mental health in population, through these new or other sources of data, or from family counseling facilities or something like that. Because we also see that it's very difficult to get good and comparable and connectable and interchangeable data from the classical sources from the healthcare system.
Okay, thank you, Alexander. Ninke has raised her hand.
Yes, thank you so much, Carmen. Yes, I would like to echo what has been said by Martin, Sarah, and Alexander. And I think this specific use case, and actually also the other use cases in this PHIRI project that Martin was presenting in the first slide, are a very clear demonstration that also for population health data, these types of cross-border research is possible because we already have a lot of infrastructures in the field. We have one for genomics, we have one for clinical trials, etc. But it's hard to get health information and health population data mobilized. And I think this is actually one of the first times that we have 4 use cases in which we clearly demonstrate that it is possible to do so, possible to mobilize this sensitive data in a federated way and to get the results in actually quite a short time. PHIRI has only started in November 2020, so we're not even halfway our project. So I think I really applaud all the people that have been working on this, and especially Martin coordinating this exercise, because it's a very nice demonstration that it works also for sensitive population health data. Thank you, Carmen.
Thank you, Ninke. Yes, I agree totally with you. What these use cases are showing us is that they really work, and the combined work from different data hubs is possible, and we can extract results and conclusions that help the data managers and all the countries to for the future to improve the access to data and to reuse them. So it's I think it's a nice exercise because of that. So I think this brings us to my next questions, that how can this use case contribute to preparedness and readiness scenarios, and also what's next? So it is very much related with a translation of the results, and also to the sustainability of this PHIRI project. So I think Joao wants to say something. Thank you, Joao. Unmute yourself, please.
Yes, thank you. Yeah, actually, it was more than an answer to your question. It was a question related to yours. And my experience with previous European Union projects or joint actions was that a great effort is put into developing web pages and giving access to the outputs through web pages. But then there's no funding to continue those web pages, which is a problem, or at least to keep those web pages fresh and new, right? So they remain, but statically. So in here, actually, the goal of this, your starting point was research questions. So my question is that, are you planning or are we planning to disseminate these results also through scientific publications? Because those remain, right, even if there's not a web page behind it. So I'm not directly, I don't know if maybe Martin can answer this.
Yes, yes, thanks, Joao. We have some dissemination plans for the future. It was a little bit busy the last time, because the last 1.5 years, because we needed to overcome these barriers, as we said, and many discussions, bilateral meetings, and so on and so forth. But we have some dissemination plans, right? We will have a meeting with some representatives from the European Commission in June, where we will present our results. We are planning, of course, on drafting some scientific publications. We try to address all the target groups that are necessary, right? We had we submitted an abstract for the European Public Health Conference in Berlin. You're very invited to Germany, all of you. So these are the first steps, but we will also draft some 2-pagers, flyers, whatever is needed, fact sheets, to also not including what I presented today, so not so much focusing on the technical part, but also something easily written, something easy to overview the key messages and to see the results. So there are many plans for different formats to reach different target groups, but these are baby steps at the moment, but we are planning on that, definitely.
Thank you.
Are there any other questions or comments or? Okay. So I think
Nike has a question.
Yes, I just want to just maybe slightly comment on the pandemic preparedness part, because I think this is really interesting that you're raising this point. So what we see is that there are a lot of different levels of maturity within Europe in the health information systems. And that coincides with how quickly data can be mobilized within countries, because we see in countries with strong health information systems, data, for example, for these use cases can be mobilized very quickly. In other countries, there's more capacity building needed, which we luckily also have provided through PHIRI. But we see that the stronger the health information systems, the stronger they are, the more ready they are actually to tackle any health challenges that come their way, including maybe COVID or also other health challenges, because we tend to forget there might be more health challenges coming. With the increased life expectancy, we have increased healthcare costs, we have the more prevalence of chronic diseases, etc. So this is also a nice test for the countries themselves, how quickly they can mobilize this data, which can be used for research, which can then in turn be used for to underpin policy-making decisions. Thank you.
Thank you, Nike. Okay, so it's there are no further questions. So I would like to thank all of you, my colleagues from PHIRI, and all the audience that have joined this webinar for making it possible, and for sharing the work we have done until now. So thank you very much, and see you in Berlin, perhaps. Okay, thank you. Bye.
Bye for
Bye.
now.
Thank you all. Bye-bye.
Bye, everyone.
Have a nice afternoon.
Bye-bye.
Thank you.
Bye.